My name is Jenna. I am, like Dr. Zanato said, I'm the pediatric transplant social worker with Norton Children's Hospital. And I'm here with Denisha and Courtney to talk to you guys today about mental health and resilience in pediatric cardiology. Our objectives today are to understand the role of social work in pediatric cardiology, increase awareness of mental and behavioral health risk factors for children, parents, and families, and to identify strengths and needs during transition to adult care phase. So social workers in pediatric cardiology can be both inpatient and outpatient, and I actually have the pleasure of kind of floating between both of those worlds as well. I follow our transplant patients here in the hospital, but I also go to the Novak Center down the street a few times a week for outpatient transplant clinics, and I see patients there outside of the transplant clinic as well. But so we're in both areas. Social workers are specific and unique in the way that we utilize a strengths-based perspective when evaluating patients and families. So this focuses on the strengths and resources of people, communities, and their environments rather than their problems or pathologies, and that really lends itself to be incredibly beneficial, especially in the world of transplant like I live in. So in my assessment, I want to talk about a couple of things that I'm looking for in order to highlight patients and families' strengths and resources. But in addition, I'm also looking at risk factors that could allow us to come alongside the patient and family to provide and supplement support as well. So all of these things are really overlapping in a lot of ways too. So I tried as best as I could to break them down into subsections. The first thing that I'm assessing for is barriers to healthcare access. This can look like a lot of different things. It can look like transportation barriers, such as can the patient get to and from their outpatient appointments reliably? Do they have a working vehicle? Can they afford gas? Can a parent or caregiver take off at work without facing repercussions? We look at financial barriers, so like an inability to afford insurance or out-of-pocket expenses. We assess for lack of insurance and provide education and directions on how to apply for health insurance or Social Security income, Medicaid, things like that. In addition, we assess for health literacy barriers. This is also a really broad topic. So specifically what I'm looking for is understanding a patient or family member's reading or education level, their preferred learning style, and historically, how has this family managed the chronic illness thus far, or have they managed somebody else's chronic illness in the family? This can also include assessing whether the patient or family knows how to communicate with their team, like who they should be communicating with, what kind of information they should be communicating to their team, when, how, or why they need to communicate. In addition to assessing whether they really have a robust understanding of their diagnosis and their treatment options. We also assess for mental health history, both history and present issues, and the impact that mental health has on access to healthcare, and provide either direct practice or connection with community resources. Social workers specifically can address psychosocial challenges, including helping those with heart failure deal with illness uncertainty, assist with end-of-life issues, and focus on treating mental health concerns related to health decline and reduced ability to engage in daily activities. So we can support patients and families with heart failure in addressing the challenges of serious illness and helping them to draw on previously acquired strategies such as resiliency, spirituality, self-care, which goes back to that strengths-based perspective that's kind of unique to social workers. We also evaluate social supports and family dynamics. This can look like assessing for caregiver supports. We see a lot of caregivers of various family structures and relationship to the patient. So it's important to understand the family dynamic to really determine how to best come alongside that particular patient. And caregivers deal with socio-emotional stressors, and we can help facilitate communication between patient and their caregiver, excuse me. Assessing for support for the family also can look like support for a patient's siblings and helping the sibling to understand patient's diagnosis at an age-appropriate level. Additionally, support for caregivers looks like connecting families to community resources. And a lot of the questions that I get specifically are about Medicaid waiver programs. Unfortunately, we don't have time to go over all of those things that are available, but I want to direct you guys to the website. It's chfs.ky.gov, and I can put that in the chat later. But that is the best website through the state of Kentucky to search for waiver programs. So if you utilize that, you can just type in Medicaid waiver programs, and that will kind of let you know what's available. And the kind of services provided by waiver programs are like private duty nursing care, personal and home attendance, home-based therapies, things like that. So super useful, just not enough time to dive into all of those right at this point. We also look at financial stressors. So these can include things like barriers to obtaining groceries, housing, clothing, utilities, et cetera. In addition to this, we really kind of end up troubleshooting for deficits and a hierarchy of needs. So we can't expect a patient or caregiver to prioritize medication adherence when their physiological needs such as food, water, shelter are not being met. So oftentimes social workers are able to help eliminate barriers to help meet basic needs so that the patient and family can address the chronic health concerns. So on a more broad perspective, social work services can include individual and family therapy, group counseling, patient and family education, information regarding community resources, referral to community resources, and advocacy in the hospital and in the community. And now I am turning it over to Dr. Courtney Smith.
Thank you, Jenna. My name is Courtney Smith, and I'm clinical faculty with U of L School of Medicine and serve as the heart and kidney transplant psychologist for Norton Children's Medical Group. I'm going to speak to you for a few minutes about mental and behavioral health risk factors of children, parents, and families coping with chronic illnesses, including cardiac conditions. First, we know that our infants may exhibit challenges in early attachment relationships. Oops, I need to advance my slide. Sorry about that. It's been well established that infants experience prolonged hospitalization or undergoing significant or ongoing medical treatments can develop difficulties with bonding or attachment. Factors that contribute to these difficulties include separation from their parents and caregivers, a lack of stimulation, and pain associated with medical interventions. These factors can result in difficulty establishing that mutuality or attunement between parent and child, lower levels of positive affect and engagement on the infant's part, lower distrust and anxiety, and delays in physical and emotional development. Next, for children with chronic illness, including those with cardiac conditions, we know that there's a high incidence of developmental delays. And related to this, parents of children with developmental delay report higher levels of parenting stress and more behavior problems in their children compared to parents of children without developmental delays. And these behavior problems can begin as early as age 3. We also know that children with chronic illness exhibit increased emotional and behavior disorders, demonstrating elevated rates of internalizing and externalizing behavioral issues, lower self-esteem, and more social difficulties. These emotional and behavioral disorders are often the result of physical limitations, requirements linked with adherence to medical regimes, school absenteeism, altered or limited social opportunities, feelings of helplessness, increased dependency, self-consciousness, and worries about their illness. Some of you may be familiar with the next bullet point, which is pediatric medical traumatic stress. It's defined as a set of psychological and physiological responses of children to pain, injury, serious illness, medical procedures, and invasive or frightening treatment experiences. Up to 80% of ill children experience traumatic stress reactions. 5 to 25% of children experience persistent traumatic stress reactions that impair daily functioning and affect treatment adherence and recovery. These reactions can include a re-experiencing of the trauma, avoidance, hyperarousal, new fears related to the medical event, and new somatic complaints not explained by the medical condition. As we shift our attention to risk factors specific to parents, but before getting to the contents of this slide, we need to quickly revisit early bonding and attachment, as this is certainly a two-way street. Infants and young children with cardiac conditions can feel very scary to their parents. Parents can have fear about or may not even be able to cuddle, hold, feed, and provide the basic care to their children that most new parents get to provide. And that's a part of developing that initial bond with their child. We should also briefly revisit the child's potential for developmental delays, as this can impact parental attachment and also just understanding of what their child needs. Now, looking at this slide, we again see the mentioning of medical traumatic stress, but this time it's parental medical traumatic stress. Caregivers may be at even higher risk than our pediatric patients, with 1 in 4 parents of children with chronic disease actually meeting full criteria for post-traumatic stress disorder, or PTSD. PTSD symptoms in parents can have significant implications for the child's behavior, the parent-child relationship, and the child's adjustment in the long term. Unfortunately, PTSD in parents often goes unnoticed by health professionals. Parents also report significant grief and something called chronic sorrow in response to their children's conditions. They grieve the loss of the ideal healthy child. Feelings persist over time as the child grows and may fail to meet expected developmental milestones, and as the child may have periodic relapses of illness, repeated hospitalizations, or as medical demands increase. Next, certainly parents of children with chronic illness may develop depression. Jenna was speaking to this earlier. They may have premorbid mental illness, and most often have chronic stress. In reviewing 30 studies of parents of children with congenital heart defects, 25 to 50% of the parents reported clinically elevated symptoms of depression or anxiety, and 30 to 80% reported experiencing severe psychological distress. These parents also have significant feelings of guilt and decreased self-efficacy. Their grief can lead to self-doubt and powerlessness, and can lead parents to have less confidence in their parenting skills in general, which may ultimately negatively impact the parent-child relationship. Finally, there's vast literature that points to how all of these factors, both the child and parent factors I've discussed briefly today, can contribute to an overall difficulty in parenting and managing child behavior. And this is also all taking place within a context in which parents are often asked to provide medical care and oversight of their child's condition, further stressing an already stressed parent-child dyad. Perhaps the take-home point when considering all of this that I've just said is how interdependent these risk factors are. A rough start attachment-wise can lead to developmental delays, or even if attachment goes well and there are no developmental delays, parental grief and guilt can undermine positive discipline practices, et cetera, et cetera. There are unlimited potential combinations, interaction effects. But I think all of us would agree that early intervention is the key. So what can be helpful? Of course, we want to listen and show empathy and compassion and provide respectful care and acknowledge and educate parents about grief, encourage them to process their grief through telling their story. We want to help parents understand their child's developmental delays and needs, promote effective parent-child interactions related to feeding, caretaking, social and sensory stimulation, and discipline. Use good communication skills between specialties to reduce giving parents conflicting information. Allow ample time to ensure patients' understanding or parents' understanding of the care that their child will need. Encourage parents to take breaks and engage in self-care. Teach active and generalizable problem solving and coping skills. And finally, be thoughtful in providing well-timed referrals to behavioral and mental health providers. Or better yet, consider an integrated care model similar to the roles that Jenna, Denise, and I have on our respective teams. As I mentioned earlier, I'm the psychologist for the heart and kidney failure and transplant teams, and there may be a similar need for a position in your general pediatric or medical specialty practice area. Integrated care can increase access while reducing stigma. For example, in the case of heart and kidney patients, everyone sees me to assess and address these above issues. It's just a routine part of the care. Thank you for your time and attention. And now I'm going to turn things over to Denise Oggs to discuss transition to adult care.
Good afternoon. Hope everyone is staying safe and warm today. My name is Denise. I'm the social worker for the adult congenital heart team under the Pediatric Cardiology umbrella. We serve patients who are born with congenital heart disease. So I'll be focusing on promoting resiliency through the transition phase, which is really important. So just to reiterate on kind of what Jenna said, I also use the strengths-based approach in identifying patient and family strengths to overall like promote and improve and make good changes for the patient and family as they transition to an adulthood and then transition into adult care. Ways of doing this is helping the patient grow their understanding of their cardiac diagnoses. Transition is usually started around 12 or 13 and kind of laying the groundwork for them and continuing as they come and see providers on helping them understand their diagnoses, helping them understand family history, and just preparing them for their ability to kind of manage their own care once they are over the age 18 or even into their early 20s. We do this by encouraging and engaging patients in conversations about their medical care. So, as a provider, going in and kind of doing a baseline of like, so what do you know about your care, or what do you want to know about your care? Building those connections and rapport with patients and family by also assessing their strengths and needs. Developing strategies to promote their involvement in care. One of the things that I utilize is setting small goals with patients and families during their visits, and kind of helping them develop when they plan on working on these goals and when we will revisit and see how they've progressed towards those goals. For instance, with one of Dr. Kurt's patients in the Fontaine Clinic, his goal for the next visit is to be able to come in and kind of tell basic information about his family history in regards to their medical care or medical diagnoses. It's important to continue to support and positively reinforce patients and families when they engage in treatment or ask questions or are more vocal in their appointments. Identifying supports that will assist them with improving self-advocacy and address other needs outside of their cardiac care. The goal really of transition is to, make sure that youth and young adults feel comfortable and confident in managing their own care, and then helping patients, parents, and support them and helping their child increase their independence and knowledge about their care. The curriculum I utilize for the patients that I work with was developed by Got Transition. It's really helpful. So if anyone wants any information on that, I can be happy to forward that information to you. But that's all I really have right now. So thank you so much. Does anybody have any questions, comments, concerns?
Hi, thank you all. That was a fantastic talk. There is one question in the chat. When working on transition, do you implement any standardized transition readiness assessments like the TRACK or the STAR RX?
I do utilize the transition readiness assessments outlined in the curriculum that I utilize. I try to give one to the parent and the patient when starting transition, just to get a baseline of where they're at. And then the goal is by the end of their transition, when they're between the ages of 22 and 25, resubmitting that assessment and seeing where the patient is at. And hopefully they have completed their transition goals.
I was wondering, I take care of these patients in the ICU, and I see the sort of traumatic effects that can happen to the parents. Even the parents can, even if their child does relatively well, I think they can have some PTSD from other events that happen in the ICU.
Yes.
And I know that in the primary care world, the visits are so short and they're so focused, and these children are so complex. I was wondering, is there one question or one thing that you guys would recommend a general pediatrician maybe ask the family to get at whether they need more resources for some of this post-traumatic stress and perhaps depression, because they have suffered such, when you get pregnant and you're going to have a baby, there's so much excitement around that. And then it looks nothing like you expected it would for a lot of these parents with children with congenital heart disease. So is there something you recommend for primary care providers to sort of check in with the families?
I'm glad to jump in. I think probably one of the best things to say is to maybe reflect on the knowledge you have that this is difficult, and that we know that a large percentage of parents do struggle with, PTSD, grief, all the things that go along with it. And so to be very sensitive and maybe leading with the fact that that's a common occurrence, and then maybe asking if they have sufficient support, or where do they talk about these things, who do they feel that they can share some of this with. And if they, don't have anything, or don't feel, that they are well supported, then of course that would be the time to maybe make a good referral to someone, either an adult clinician, a family clinician, or sometimes people prefer to talk to someone at their church, or, another type of resource. So I think just maybe it's the sensitivity and the way I think of approaching the question, so that, and I think that's what you're getting at too, is how do you do that without making it sound like there's something wrong with them, when in fact I'd say that I think I said upwards of 80% of parents struggle with it. So it's nothing unusual or uncommon. And in fact, probably the other 20% does too. It's just everyone's different about how willing they are to share.
For sure. And I noticed that there's some of our inpatient nurses and ICU providers on the conference, and I'm just wondering if you have tips for things that we can do in the ICU to increase bonding and increase the interaction of the parents with their child, even when they're critically ill.
And sorry, you kind of blanked out a little, but I think you asked about helping them interact with their children. Yeah, I do try to encourage parents to, ask, because sometimes I think they don't even know that it's okay maybe for them to pick up their child, or to, change the baby's diaper or something. And I think sometimes they may need some teaching to do that safely, but I think our nurses are great at trying to include the parents and get them involved. But I do encourage parents to ask, what is it that they could do for their baby, or, could someone help get their baby into their arms and let them sit with them for a while every day? Certainly learning from the therapies that come to bedside in terms of developmental play and how to engage them is super important. When they're here months and months and months, for instance, waiting for an organ, we don't want them to just be laying there and not very stimulated, if they can handle the stimulation. So I always encourage parents to ask, how can they be involved? But I think our nurses do a great job of also kind of enlisting them and encouraging them too.
I agree. Absolutely.